All right. We will now transition into our first panel discussion for the day. Yep. Okay. Okay, thank you. After I... All right. We will now transition to our first panel discussion for the day, titled Beyond the Bedside, the Nurse's Perspective in Addressing the Black Maternal Health Crisis, moderated by yours truly. Our first panel member is Tiffany Vassell. Tiffany Vassell is a registered nurse who has worked as a labor and delivery nurse in Cambridge, Massachusetts for several years. She has also served as a substance use nurse assisting patients with their recovery at local clinics in Boston. She is a Black maternal health advocate who supports midwifery care, equity, autonomy, and access to home births and birth centers. Sarah Dominique. Sarah Dominique is a registered nurse who works in a labor and delivery hospital setting in Cambridge, Massachusetts. She is also a candidate for a Doctor of Nursing Practice degree in women's health at Boston College. She developed a passion for women's health in college and recently became interested in improving maternal health equity in and out of the hospital. And last but not least, Kanisha Friend. Kanisha Friend is a former public school educator and full-spectrum doula. She currently works as a labor and delivery nurse in Boston, Massachusetts, while pursuing her advanced nursing degree in women's gender-related and adult health at Massachusetts General Hospital Institute of Health Professions. Her passion for improving health outcomes for marginalized and at-risk mothers bloomed at Syracuse University, which led her to launch mybumpteam.com. A digital platform that makes it easier for maternal health providers to manage their business and stress-free for parents to manage their pregnancy to postpartum experience. Thank you. And so we will start our panel. And also, Kanisha was my student. All right, so we will start with the first question. Please share why you chose to specifically become a labor and delivery nurse. And before that, I'm going to pose another question. What parts of your nursing program training do you wish were more tailored to Black birthing people, and how would you change them?
I'll start. So I came to nursing late. I became a nurse at 32 years old. And the idea came about when I got pregnant with my first child. The experience of having her wasn't quite ideal. I went in and I felt like I was being pressured to move it along. We have to hurry. We have to hurry. And at a point, the doctors came to me and said, you know, if you don't progress soon, we're going to have to section you. And it was at that moment I felt like, I don't want to say I became like violent, but I felt like I had to be aggressive. Like, no, you're not going to section me. Like, you're absolutely not. Like, I need time. And I really had to advocate for myself. My mom, my sisters were in the room. I had a sister that was like, just do what the doctor says. And I'm like, you can excuse yourself. You can leave. And one of my oldest sisters, she my biggest supporter, she's like, I'm going to stand with you. Whatever you need, I'm going to be there. And 4 hours after that, I had my daughter vaginally. And thank you. And it was that very experience that I felt like I needed to be a nurse. I didn't feel listened to. I didn't feel supported. I didn't feel encouraged. I didn't know what a doula was at that time. Again, I wasn't a nurse at that time, so I didn't understand the hospital process. And so I really felt lonely and I felt lost. And I decided that I wanted to be that advocate for women who are having their babies and give them a voice and help to give them that time that I requested, right?
Thank you.
So with the nursing program, with the nursing program, we probably only did 6 weeks of maternity. It wasn't very much. I was in an accelerated program. It wasn't very long. So I wish it was longer. I wish we reviewed more of the disparities. We didn't touch on it. It was just very basic, the physiological process and fetal monitor tracing. But I wish we really dived in and talked about the disparities and really what birthing people need at that very special moment.
So initially I went to school to be a midwife. I went back to school to be a nurse, didn't get into any midwifery programs. So I'm like, okay, what's my plan B? And the plan B was to be an L&D nurse. But this is after thinking about what did I want to do. My first bachelor's was in psychology, and I wasn't really happy doing the work that I was doing. So essentially, as you had shared earlier, like in college, I started learning more about the midwifery role. So now back to ABSN, and I'm gonna do L&D because I did my senior practicum on an L&D unit, and I actually didn't get the job. And I was crushed. And I got a job in pediatrics, which I ended up loving. It was challenging, but I enjoyed it. But it wasn't until 3 years later that I actually worked on the L&D floor that I did my senior practicum in. So there was a lot of little, twists and turns there, but essentially that's how I ended up on L&D. But I always knew that I wanted to do women's health. So that's the answer to that one. And then in terms of education, definitely as a student right now, one of the courses I'm taking is diversity in nursing. And I find it to be very helpful. I feel like I've learned a lot in the course myself. And, they talk about topics like social determinants of health. They talk about equity, power, privilege, things like that. I didn't get that in my undergraduate or like my bachelor's in nursing. It's in the doctorate program that they've incorporated that, and I think that's something that should be for all nurses. It shouldn't just be for advanced nurses, because it's something that we all have to deal with as nurses. Social determinants of health that, you touched on earlier. I didn't learn that there was a Black maternal health crisis when I was getting my bachelor's. That's something that we should be talking about for all women that will have the desire to, have a baby. And then representation, and you also mentioned just Cassandra, but, representation in education and leadership, the student body, I think those are all things that matter, and can enrich learning spaces.
I became an L&D nurse because in 2021, I was working as a full-time teacher, and I was also a doula, but because of the schedule, I mostly did a lot of postpartum work, or I would do prenatal education. So I would always partner with other doulas who had the time and availability to go to a birth if I'm in class or teaching at the time. So it just so happened that the client that I had, she was a teen mom, and she also happened to be homeless. And we did a lot of work during the prenatal part, a lot of education, and school was on break, so I was able to attend her birth. And so we were in her birth room, and her mom was there, or a family friend rather, and we did a lot of work on confidence, how to advocate for yourself. And then something happened. And then, now what I'm thinking, it may have been a decel now that I'm in L&D, but something happened and so many people came rushing in the room. And I just remember seeing how everything just left. All that power that she had, all the confidence, me feeling like maybe I wasn't doing enough, because at that point, I didn't know like fetal heart tracing. I didn't understand that stuff. That wasn't my role as a doula. And I just remember feeling really just defeated, and I saw her feel defeated as well. And it was in that moment where I was just like, if I'm going to be in the room, I don't just want to be an extra person, an extra body. I want to be able to add on to the knowledge. I want to be able to continuously advocate for my patient. And so I said, it was like literally in that moment when I ended up going back home, and I was like looking at nursing school and everything. And I said, yes, the next time that I'm going to be in a delivery room, I'm going to know exactly what's happening. I'm going to understand the sounds. There's nothing that's going to be separated. So I feel still that being a nurse, but also trained as a doula, like it is the perfect like marriage, because it's one thing to have the skill set, but it's a different thing to have the philosophy. Like nursing philosophy is one thing, but being a doula, the way that we are taught, what we prioritize, that matters. And so that led me to becoming an L&D nurse now. As far as school, so I also went to an accelerated program, and the maternity course was 6 weeks. And I do think for 6 weeks, it was really good. I felt really confident. I felt great about it. The one thing that I think they could do better is really challenging like diagnostic criteria. So we know that there are faulty, right? We think about BMI, like that's faulty. When we talk about the way that we categorize patients and how we make them to become medium risk or high risk, we have to question things. And I think more could have been done in that regard. The second thing is, I remember this because she actually looked at my LinkedIn the other day when she saw I was in the conference. I got in an argument with my professor during class because she was saying something that was just wrong. Like she was just disparaging to doulas. She did not like doulas. It was very clear. And she made a statement about yoni eggs. And I was just like, okay, I won't tell all her business, but she made a statement. She made a statement about yoni eggs, and I just, responded to her. And she said, well, where's your research? There's no research that supports that. And I said, research is expensive. To think that, like, what happened to, like, anecdotal evidence, Like, just to say that it's not real because it's not supported by or it's not in a medical journal is ridiculous. Like, there are so many things that are true that just don't have the financial backing to be able to be researched formally. And so I think that needs to be a part of the curriculum as well. Just because it's not in a medical journal does not mean it does not belong in the classroom.
Thank you. During Dr. Omuta Onukaga's opening address, she mentioned that maternal death rates surged by nearly 40% during the second year of pandemic. Widening disparities as Black women again faced alarmingly high disproportionate mortality rates. Can you share your experience of working on the labor and delivery floor during the pandemic? And what is your key takeaway from this experience of working during the pandemic?
I'll go first. So I talked a little bit about twists and turns. During the pandemic, I was working in an OBGYN clinic, and I loved it. I thought it was a great place to be, especially knowing that I did want to go back to school to advance my degree in women's health. But I just remember, that call in like March, it's like, all right, now we're going to go to, from going in person to like seeing patients or talking to patients remotely. So I was going in 2 to 3 times a week. And kind of just doing like injections, not really able to speak to a lot of the questions that patients had. And there was just so much uncertainty. So that was really challenging. Fast forward to June, I got furloughed because of COVID. A lot of the nurse practitioners were doing the triaging, and so they were able to bill for that. And then kind of like the RN role was kind of going away in some aspects. So I was a little devastated. I already felt like maybe I should be in the hospital, really helping, really being in the forefront, really being in the front lines. And being in the clinic, it didn't really feel that way. And then, having losing that sort of touch and talking to patients in person. Now I'm furloughed. I'm like, what am I going to do? So fast forward to October 2020 is when I actually got my first L&D job. And so in terms of answering the question, like the first part is it's hard to answer questions that patients have and serve them and meet them when you don't have like the tools. It's hard to be helpless as a nurse because you enter the profession to be helpful. And then now on L&D, it's like something that's so intimate. You're like putting on this gown, you have a mask on, they barely see your face. It's like, conversations and counseling about, you have COVID, there are like harmful risks for you if you keep your newborn next to you and how hard that could be for the mother who just, birthed the baby. It was so nuanced and it was challenging. So that was my personal experience during, working throughout COVID. And even like present day, when we had to get vaccines, there's a lot of uncertainty there, people who were pregnant, being mandated to take the vaccine. I'm not, standing either way, but that's a hard decision to make for anybody. And so the takeaway I would say is, silver linings for me, cause it helped me to, apply to go to BC. I got to work in L&D. When I wasn't working, I had time that I didn't think that, just being home and thinking about my choices and my options and feeling safe. So just silver linings despite everything going on.
For me, for majority of the pandemic, I was still teaching and I was in Houston, Texas at the time. But when doula care wasn't in Texas, like at least, doulas were like quickly not allowed inside the hospitals. So everything shifted within a matter of days. And I just leaned on what I was already doing, which was virtual. Like I was very good, like Google Classroom, all this whole thing. So I ended up making just different videos and like curriculum for expectant parents, and I would just post it on Facebook, post it on Instagram. And I had parents come from, there's like a lot of Facebook groups for parents, and so it's like, due in August, like it's a lot. And so I just post in there and I'd say, okay, here's some education. And so I had a lot of parents from around the nation just like join me on Zoom, and we would go over what to expect, what things you might see, what questions you might want to ask, bring in like and debrief their prenatal appointment or debrief their birth. And it was just like this really safe space. One thing led to another, and I just, again, when I was a doula, I would just make sure that I was collaborating with other providers. So in Houston, I was pretty good and pretty known for like, if you come to me to be your doula, you're going to have a Webster certified chiropractor. You're going to have a lactation coach there. You're going to have a postpartum doula. And so it's like, you come in one place and you get like this inclusive care. And so when you add that on with prenatal education that was virtual, I said, okay, I have something here. So on my website, I was doing everything manually. And I started doing pitch competitions because I was like, you know what? I feel like this can be a full-fledged website instead of me manually doing everything. So for much of the pandemic, I was literally just like talking about the maternal health crisis and just trying to get funding for this idea that I have. And that was about 3 years. And so now we're at the point where all of that like beta testing, getting feedback from parents, it's finally come to fruition, and we're launching at the end of the summer.
The pandemic for me, because we're still in the pandemic, a very uncertain time in the hospital, very scary for patients. I'm scared for myself. I'm scared for the patients, of course. And just wanting to provide a great experience and ensure that the patient is getting the type of experience and moment that they want for themselves, for themselves and for their families and their babies during this delivery. You know, we lost a lot of nurses, and so severely understaffed, under a lot of pressure and stress. Everyone was very worried. It was a very difficult time, you know, just having patients be reduced to not, you know, having who they want in the room, you know, at a point, patients maybe not being able to bring in their partners with them, you know, you're not able to bring your doula, not able to have your support system. And then we have these masks and these bunny outfits, and it's so distant, but we're so close, you know, having to push with a mask on. How can you push with a mask on? You know, feeling just restricted to the room. You know, if you have COVID, your support person may not have COVID, but guess what? Now they can't leave the room. And just having to be confined to this room for, you know, if you have a vaginal delivery, maybe 2 days. If you have a C-section, 3-4 days, you cannot leave this room, you know. I felt scared for patients. And when vaccines came out, I thought it was God sent, you know, because it gave us a little room, and we felt a bit safer, and that we can allow patients, yeah, you could take off your mask, I'll keep mine on, you know, so that they can push without feeling restricted. It was just a very scary time. It is still a very scary time, and I feared for my patients' health. You know, we got a lot of birthing people who are very, very ill, having to deliver their babies and, you know, have the baby on one side of the room and they're here and, you know, they don't want to breathe or touch the baby because they're so ill. But as it eases up a bit, and we're not quite back to normal, but it feels almost like normal, I'm really grateful. Yeah.
Thank you for sharing that. It definitely made me pause and reflect, because I had my son in 2020, and I remember everything went well, and I remember right before you know, I was ready to push, my OB looked at me with his thick Egyptian accent and said, "Take the mask off." And I was so happy he said that, because secretly I was going to anyways. But I definitely can resonate with what you said, and I think it's appropriate to, I'm going to skip the next question to ask this question. For expecting Black parents, given the reality that many pregnant people of color will be birthing in settings with white doctors, nurses, and midwives, how can the anxiety for birthing people of color around the racial ethnic inequities in maternity, morbidity, and mortality be mindfully and respectfully addressed with the clients themselves to support optimal birthing experiences?
I would say, okay, so how can the parent advocate for themselves? Is that what that one?
How can the anxiety for birthing people of color around what is happening be mindfully and respectfully addressed?
Okay. I would probably say attending, I think conferences like this are really helpful, just because I think easing the anxiety, I think number one is just education, right? The more you know, I think the less fearful you can be, but then again, it's also on the flip side, you don't want to have too much education. But I think attending different speakers, attending different events, reading different books, different style of podcasts, like whatever way is, I think, less anxiety inducing for you that you already know, just practice that way. So like for some people that is like, I'd rather just read. Some people are like, I can listen to a podcast better, or I can hear from different birth stories, and that helps me. I think when you go into, as a parent, you go into a birth setting and they kind of like diagnose you and say you're medium risk or high risk, find out from other people. Even like YouTube is really amazing. Find out from different people and just hear their birth story, because when you do that, you're able to hear different opportunities that they had. Like, it does not mean an end all be all because you have this one thing that you've been reduced to. And then talking to, I think when we talk about getting out of the hospital, especially if you're giving birth in a hospital, like they have like, okay, if you come here, we have our own lactation consultant. We have our own prenatal education classes. Step away. Like it's a business. So you have to be able to say, you know what, that's your perspective. Let me find different perspectives just to like increase my own knowledge and take what works for me and what doesn't. You have to pick and choose.
Thank you.
Yeah, so I want to answer not only as a nurse, but as a mom. I would, if I had a provider, I would feel really grateful if my provider says, hey, I'm aware of the disparities with Black women, and I want to ensure you that I'm working on addressing my bias, and I'm here for you. I'm going to listen, and I want you to communicate your needs to me clearly. I would really respect that and appreciate that. But also, I want providers to know that our patients have the right to autonomy and choice, and they should be able to select their birthing location. So hospitals are not the only place you can have a child. You can have a child at home. You can have a child in a birth center. You can have your child where you want to have your child and with the provider that you want, right? CPMs, yes, okay. CNMs, you can choose who you want to have your child with. So, yeah, I think that's what I would respect.
Yes, you're absolutely correct. I think when discussing this, it shows how, there's a stigma and stereotype with Black women being assertive, and, and that comes with it. And I know that it can be a double-edged sword when you're in these spaces as a patient, because then you also feel like you're not being heard. Next question? Or did you want to answer?
I mean, I would just echo what you both said. I think the education piece is important. I feel like too many times when women or birthing people are rushed to make a decision without really understanding what they're choosing. Options may be provided, but it's like there's a cascade effect. There's a domino effect to like the decision that you make. And sometimes, unfortunately, I don't want to say this, but it's like time sensitive. And so, we don't get the chance to really talk about, if you break your water, this baby might come down the wrong way, like other complications that could happen. But I think that's also why it's so important to have, outlets for education, like you were talking about, to hear other birthing stories, to know that, like maybe you got this title of high risk, but you can still have a vaginal delivery if that's what you would like. And then you said something that I was like, oh yes. As like providers, talk to your patients. They're human people. They're human beings. They have wishes. Ask them what they would like. It's not that hard to just, ask them how their day's going, or just kind of like making that relationship connection. That's so important to kind of breaking the barrier and making it less transactional. And, you kind of feel like maybe the provider's here for me. That's what I would add.
Thank you. How can nurses better support moms and babies from minority backgrounds? Is it implicit bias training, offering resources? What advice would you provide to nurses across the country who care for women of color?
I can go. So first, I would like to say that we need to diversify the perinatal workforce, right? We need more Black and brown nurses. Yep. And we need to pull people into the profession from early. We need to, kids in grade school should know about nurses, It doesn't just start at high school when you're a senior. Oh yeah, you should be a nurse, It's a seed that we have to plant early, right?
What advice, sorry, I'm just so deep into what you're saying. What advice would you provide to nurses across the country who care for women of color?
Okay, so be sure to listen and take the time to truly listen, right? Try to communicate, try to fulfill what the patient is requesting, right? It's their moment. we need to center them. We are there to support them, right? We're the supporting cast. They're the main role, right? We're there to help them in this beautiful moment and ensure that it's a safe and beautiful moment. So really take the time to listen and communicate. And yeah, I think that's what I would say.
I think listening is huge. Lucinda, you mentioned this. Listen to your patients. Let them be seen and heard. You know, like, I don't feel well. Let's explore that. Why don't you feel well? Is it, you know, fear, or is it that something's going on in your body that we need to assess? I think implicit bias trainings, class, speak up, things like that has helped me. My diversity class that I mentioned already, definitely having spaces to do that in person so you can ask questions and get feedback. I think, you know, virtually is great, but having those small groups where you can continue to, you know, probe and, you know, make your mistakes before you go and, you know, make this patient feel so, feel not themselves, feel like how they shouldn't be feeling in a place where they need care. And then I think, you know, hearing more stories. I think one of the things that made me really passionate about this topic was just hearing stories of mothers unfortunately dying. It just made me upset and angry. And I was like, why? You know, like, this disruption is not okay. Like, this baby has no mother. This family has to take care of this child. Like, how are you going to explain that? I don't think that's, anyways, I'm getting a little riled up. But, like, we need to hear from patients and hear, like, what happened, and then we can take that and kind of, you know, move forward with that to say, okay, here's an area that we can work on. We have, you know, a story here that can help, you know, open our eyes to see, you know, some flaws.
I would add, you definitely need to know the community that you're working in. Know what are the top risk factors, right? Social determinants of health within that immediate community that you're working in. Because when you think about pregnancy and delivery, this is where all of those conditions kind of come to head, right? And so you have to really understand how to treat those, how to understand those, what is actually plaguing this community. And then you also need to understand what are the community resources that are available. Like, I'm speaking from, like, the hospital standpoint now because I'm working in a hospital, but it's, you know, this hospital setting, it is not all knowledge does not only exist in that hospital, right? You need to make sure that you are giving patients all the resources that are available. Like, when they leave your office, when they leave your appointment, it should not stop there. Like, they do not need to just only come to you to understand what's happening to their body. And so I think that's really huge. Make sure that you know what's going on in your community. The second thing is triage. As a nurse, you know, there's so many, like, electronic medical systems now, right? So, like, Epic. Okay, well, these are the only questions you need to ask in order to move on to the next patient. No, continue on. Dig deeper. Like, just because Epic is saying you need to ask this one question, figure out if you need to go in a little bit deeper. It should not only be yes or no responses, right? Get the story so that you can, like, track that even better, because there are so many missed opportunities that really come to head, again, when it's in this emergent situation and, you know, they have to make that quick decision. But if you were able to understand, if you triage better, then you would be able to help them earlier on.
Great. Next question. For expectant Black parents, what are some of the most important health care related decisions that they can make or questions they can ask before delivery to facilitate a smoother experience?
I would just go back to just asking them, okay, do you have any community resources for me in between appointments? What worries you about my history? Okay, what would be your course of action? Right? Like, ask them. Like, we should be, as nurses, as your provider, you should be able to explain to them, okay, because of this, I'm thinking of this. And then at that moment, you're able to say, okay, thank you. You take that information back, you do your own research, come back, and you say, you know what, last appointment we discussed this. I'm thinking this. These are other options that are available. Because sometimes providers just do things that they're comfortable with. Like, we have, you know, parents usually come in saying, okay, well, I want to give birth in this position. And I was like, yeah, sure, why not? And then I got pulled aside. This was like my first month, and they were like, no, she can't give birth in that position. I was like, what do you mean, why? And then the nurse whispers like, well, because the way that doctors are trained, they're only trained when they are supine to give birth. Like, she doesn't know how to catch a baby unless the mom is supine. And I was like, well, that's not. So I think like that's a really big thing. Figure out those answers and like push them a little bit more.
So I think what I would tell patients when they're coming in, what they should come with or be prepared for, definitely a birth plan. I think it's so important to think about the type of birth you want, who do you want in the room, the type of interventions you want. It's good when you have an idea prior to, and again, you're not in the delivery room and someone's asking you like, do you want all these meds for your baby? And then you feel pressured about having to accept a med that you may or may not have wanted. I think it's so important also to do healthcare proxies. Please, please, please do those in office. It's so important. God forbid anything happens during the labor process. We want to fulfill the patient's needs, right? Or their request. We want to do what the patient wants for themselves. And then, of course, having an advocate with you. Talk with your advocate, your partner, whoever it may be. Let them know your needs, your wants, and have them be there to be assertive for you. Because when you're in pain, sometimes you can't respond, or you don't want to respond, right? And you're tired, you want to sleep, you want to rest, you don't want to speak at the moment. Have someone there who is willing to really be that voice that you will need in that moment, whether it's your partner or a doula, whatever support person.
And to add to that, I think it's huge to educate yourself. I mean, I think you both touched on this. Don't let the first time you learn about pregnancy be when you're pregnant. It's too late. Like, there's so many things involved, especially when the baby's born. Do you want to breastfeed? The medications, like you were mentioning, it's a lot to learn at that time, especially when your body's going through all those changes and maybe you're tired, maybe you're nauseous. It's like so much. So I would just say, start the process when, maybe you know that eventually you want to be a parent. Obviously, life happens. Maybe it's an unplanned pregnancy, but just, I hate to put it back on the patient, but it's really important to, think about what you want for when this happens, and just keeping an open mind as well, because birth can be so unpredictable.
Thank you. And the last question, what are ways that doulas can better support nurses in hospital settings while still advocating for their clients?
So when I walk into a room and I see a doula, I'm like, yes, yes, yes. I'm so excited because it's teamwork, right? Teamwork make the dream work. Doulas are with patients throughout their pregnancy. They know the patient very, very well, right? When you come into the hospital, I'm with you for 12 hours, maybe 24 if I have a shift back to back, right? I'm just with you for a very short moment. I may or may not celebrate your baby's birthday, but I'm with you for a very short time. I love doulas. I think they are great with body positioning. They're great with calming the patient. They are great with communicating with the healthcare team so that we understand the patient's needs, especially at a time where the patient may be in pain or maybe sleeping or just may not want to talk to us. So, I love them, and I wish more doulas were in the hospital. They are a great tool to have there. They are a great team member, and the work that they do is very meaningful and very valuable, and we should treat it as such.
Sorry, I want to just add to I keep adding. But yes, doulas are great. They're amazing. Our patient population, a lot of them speak different languages at home, and English is not their first language. A lot of times our doulas speak their native language. So I think it's huge. You know, they're not supposed to be the translator, but sometimes they do. And so that's an added benefit as well. Just like you said, it's teamwork. So I come in, I know that there's a doula here. I feel a little bit better when I walk out, so I can go do this documentation real quick, get your water, and come back, and like now we can do this birthing thing, you know. Like, it's definitely nice to have them around, especially for our patients who want to have a natural childbirth. And early labor can be long, you know, and maybe that doula can be with them at home, but if they're not, maybe they can come in and kind of like support and continue to be, you know, positive reinforcements. Yeah.
I would say, for better or worse, there isn't any standardized doula education, right? There's no standardized doula training. And even with that, there's no requirement for you to be trained formally, right? And so when you are entering a setting, again, just speaking from like this hospital setting, you know, some doulas have given doulas a bad reputation. Maybe it's because some may have like acted out of scope. And so you coming in with your client, you're kind of having to break that a little bit, because you have like these nurses and like, oh no, they're going to come in with this. So they're not giving you a clean slate. And so as a doula, when you come in, I would say just kind of set yourself up to remind the nurses that you are different. Whatever their past, whatever their bias is, you're just going to address that head on, I think, very early on. So one thing I love doing is just going in there and say, how can I make your job easier today? And so they will may show you where to get ice, where to get pillows, where to get warm blankets, all these different things. You figure out very early on the lay of the land so that you can be more independent with your client. I think the other thing as a doula, when you're there for the patient, is always let the patient speak. Like, I would just give a cue to my client. I would say, if you need more time or you want to discuss it in private, say that. You don't have to make the decision with them in the room. And so when the nurses or providers are there with the patient, okay, say whatever you want to say. And then I give my look. We all have our signals. And then the patient goes, I'd like to discuss some more time to discuss it. Once they leave, you guys have your conversation. But always let the patient speak to their provider as the doula.
All right. Thank you very much. And we have just a few minutes for questions, if anyone in the audience has any questions for our panel. Oh, okay, we have a question up here.
Your hand again. Sorry. Okay. I just wanted to know the name of the platform that you're launching at the end of summer. I'm stoked.
Oh, yay. So providers can join for the wait list, and parents can join as well. So it's mybumpteam.com.
Oh, thank you. So let's say a student came to you and she's thinking about going into nursing and she wants to be a labor and delivery nurse. What advice would you tell her?
You guys are longer. I'm going to let you take this.
So I think I have some experience with this. So definitely encourage. I love to hear it. I definitely take them right under my wings. So I think a lot of time it's about networking, right? It's who you know. I got my position because I knew a nurse manager. So get out there, network. If you're in nursing school, you're doing your practicum, you're doing your clinicals, make relationships, get numbers. Hi, my name's Tiffany. This is my first time doing my L&D rotation. I'm excited. I love it. Can I have your number, please? Can I have your email? Can we connect afterwards? So I would encourage students to network, try to stay in contact. Professors, a lot of times, you take your L&D coursework. Professors know people. Hey, I really want to work at this hospital. Can you connect me to anyone? A lot of times it's about relationships, right? I feel like the L&D stuff, you can learn it, but the network stuff takes a lot of work, right? And the L&D stuff, it's like over years, right? You're a novice when you first start, so that stuff eventually clicks, but building the relationships is what's really important, and you have to start early. So I would encourage them to start networking as soon as they can, collecting numbers, collecting emails, staying in contact, showing interest, right? People like when you show interest, right? It makes you want to share more information or say, hey, you know what? I know someone I can connect you with, and they'll help you get a job on L&D, or, just a lot of following up and ensuring that those relationships are really strong.
And then join professional networks. Because then when you join a professional network, when you're on the floor and you're an N of one, you have your professional organization to go back to of nurses who then can mentor you and hold you in for the moments where it gets really hard, where you want to leave. And I can say that that's what the beauty of the professional organizations such as New England Regional Black Nurses, where I was the only one but had a home to go to and didn't leave the profession because I had a family of nurses holding me.
Absolutely.
I would just, I hate to be so serious, but I would just say, are you sure? Because the work that we do it can be taxing sometimes. I've had recent experiences with pregnancy losses, and it's tough. Like, you walk away from that woman and you think about her, like, when she's not in the room, when you're not at work. And maybe that's just a challenge for me because I'm kind of early in this stage, but I would just, ask them their why, because that's what they're going to keep going back to anyway. Like, why do you want to be a nurse? Why do you want to be an L&D nurse? Okay, cool. Let's stick to that. Let's hone in on that, and let's get you prepared for that.
I'm a new nurse, and I'd say getting L&D was, it's difficult to get a specialty as your first nursing job. And I went to like every open house, and I stayed connected with the HR person. I just emailed her, how's your day going, and things like that. And so we formed a relationship. And then, when it was time for, they were doing interviews for L&D, and I was like, and she said, Kenesha, you need to have 3 years experience. I said, yeah, just put me down. It's okay. And then, so I risked every other open table because I had to wait for that L&D table to open up. So I was like, oh my gosh, I hope I get this. So I sat down and I just started talking. I was like, yeah, I know I don't have enough experience. I know that's what you're going to say, but here's my resume. I want to tell you what I did. And I just went down everything. I didn't even give them an option to tell me no. Like, I literally just started talking. And then she goes, thank you. And she said, okay, well, why are you interested? And I was like, oh my gosh, this is an interview now. And I was like, okay, it worked. So I just kept going, and that worked. And then I had to meet with the entire staff a week later, and they were like, it's a little early, how are you going to manage this with school and everything? I said, well, I've been preparing, and you have to give the whole thing, because as much as you're interviewing with the manager, you have to interview with the staff as well. So I would just say, if you're interested in L&D, just get experience in other ways. One thing is you could do an internship. You come with a project for a hospital. You're a doula, that is an internship. So this is what I did to help the hospital. This is what I the patients that I had, and this was the outcome. There you go. That's your internship there. I'll stop there because we have a minute left. But there's different ways to just work around it.
All right. Well, thank you for such a wonderful and engaging conversation.